So today we're going to be doing basically how to transition. I'm going to give you guys just an overview because there's a lot to learn, and I'm finding us as therapists are as stressed out as our clients, and it's hard to retain information. So you will be getting these PowerPoints afterwards. We'll be mailing them to you. You should be getting them in an email. I see Erin's on there. Erin, you can hear me just fine? Maybe she can't hear me. She's connecting to audio. Okay. And so we just want to be able to get as much information out as possible. We're available. We're going to be having this Wednesday a talk with our biller, who's going to be on to help everybody out. I'm going to try to clarify some things, but if there's any other questions that hopefully we'll be able to help, we're going to be doing a lot of other things that are supportive. So don't forget to follow us on Facebook, which is probably how you heard about us here today, also Instagram and our regular website. Well, let's get started. Some of the things I'm going to be talking about today are the basics for getting started, a little bit of billing. I'm not going to go spend a lot of detail. You'll see that in there. It's self-explanatory. A little bit about psychotherapy, and really what I wanted to focus on is kind of acute trauma, both acute stress, technology, and questions at the end. Okay. So we're going to first just kind of what is the very basics to getting started with regard to dealing with individuals online. Are they appropriate or not, right? So really assess the technological competency of that client. What concerns do they have? A lot of these concerns you should have, right? So what type of, who can hear them where they're at? Who can hear you where you're at? I see some people with headphones. I like that. Earbuds is oftentimes what I use with clients. Even if you're home, just as an extra layer, if someone happens to be that they can't hear you or your client, it's going to be very important that you're in a place that's very secure for your client. You also want to make sure, is there anything that they have concern? Is there any abuse in the house? Are there other family members that they don't want to hear about their concerns because they don't want them to worry about them worrying, those kind of things. Where's your clinical situation at home? Are you in a spot that you're pretty secure, that no one's going to hear you when you're talking to your clients? Are there other concerns that your clients have? What are your concerns? Because oftentimes we can send a vibe. Think about when you see your patients that are nervous and anxious and their muscle tone, you recognize all that, right? You being unfamiliar with telebehavioral health, you know, sometimes that anxiousness can come across, and you kind of want to limit that the best you can. Also things to think about. Do you want your appointments recorded? Because many of these audios, like I'm doing now, I'm taping this, and I would suggest anybody that doesn't want to be on, let me know. Actually, let me get this out of the way. So is because people can potentially record. If you're going to record an appointment, should you, you know, oftentimes with trauma, we do record the sessions and repeat it. You just want to be clear about what's okay and what's not okay as far as the client or yourself. The appropriate, do the patient or the client, are they competent? Have they never used any type of technology before? You know, what do you do typically on the internet? You can just start a general question, right? So do they ever do searches? Do they shop? To some degree, you're looking for that depth of what knowledge, you know, what software are they familiar with? Some people know FaceTime, because oftentimes you want to use language that's familiar to the client. It seems less stressful if you're saying, hey, we're going to do something like FaceTime rather than we're going to do virtual therapy. It's not as intense of the words that you're using, can oftentimes feel comfortable to clients when it's familiar. You know, how often are they using the internet? And you're just trying to gauge what is going to be helpful, what they're going to be able to do or not do. You also want to know is what type of devices do they have? Do they have smartphones? Do they have tablets? Do they have computers? I know we have watches that can do things, smart watches. So you just want to, all they need, right, is a microphone, video in order to make that connection appropriate so that you can interact with them. And ultimately, as you see me, it can be very close. You want to be aware of where you are in your position to the computer or sitting back. And ultimately, even with clients, you want to be able to see a lot of their body. So if they're tapping their foot or moving around, you can read their body language. It can be a little bit more difficult using virtual to kind of recognize that. So just be aware of how far away you are from the screen, how far away the patient is, and you can always ask them. Also, lighting. You probably can't see this here, but I have supportive lighting here because this room isn't particularly have that much natural light. So these are things you want to consider where you are. They also have pretty cheap, inexpensive lights that you can kind of either put on top of your phone or put on top of your computer. And I would say, from your perspective at least, have the biggest screen possible. You want to be able to see that client so that you can read those nonverbals oftentimes. All right. What I'm going to do is, everybody, if you could hold, we're going to have a pretty robust Q&A at the end. So I'll be checking, make note of those questions and save them to the end. And we'll if you can type them in the chat, that'll be a great place for me to be able to see them later on. All right. So what happens if the client does not have technology limitation? What do? Do you not give them care? So one is, you could refer to someone maybe in a different location. Depending on the state you're in, there's different ways of what you're allowed to do. So are you considered an essential worker? Here in Pennsylvania, we are. Even though we have chosen as a practice not to do face-to-face because we want to help mitigate, and we think virtual is a strong option for our practice. And so we have switched, as of last weekend, we switched, and we moved all our clients over to virtual. And so that has worked well for us and most of our clients. Now we're a traditional outpatient mental health clinic. We take mostly commercial insurance and Medicare, so most of our clients are in a position where they have some type of device that allows them to be able to do it. However, if it's technology, some other limitation is how can you educate them, maybe to be able to, do they have a significant other, a neighbor, a friend? Hopefully that's sanitized before they get that device and they use it. Or worst case scenario, if the visual piece cannot be, telephone is another method that you can use in order to connect with that person to continue to get the care that they're looking for and they need. So you just want to kind of begin to look at all these different levels when going into virtual therapy that are going to be important. So what's the benefits of virtual and telephonic sessions, right? So it helps mitigate the risk of the COVID-19 virus, and that's why we're in the situation we're in. So oftentimes what we're trying to do is really just help the client through the stages of change and really just highlight the positives of this. It's convenient, right? There's no need to contend with traffic, which there doesn't tend to be a lot of lately, unfortunately, or rushing to appointments. It easily fits into their schedule. They can be anywhere, sometimes even in their car. If that's the only safe place that no one can hear them, they can sit in their car in their driveway or somewhere else or in a park if they're able to get out of the house and drive, or walk for that matter, in a place where no one can hear them. You have expert resources right at your fingertips, so I can go here while I'm on a session with someone and make a recommendation, pull it up, cut and paste it right into the chat, and they can click on that link. I can share the screen like I'm doing now, and we can use worksheets or other tools. I do a lot of cognitive therapy, cognitive restructuring, and cognitive forms that I can do and we can do on the screen. Oftentimes, many computers allow you to write and draw on the screen. And weather will not be an issue as far as using distance. It can be private, right? It's secure conferencing technology. We use Zoom, but there's others. There's VC, as well as many other different telehealth. Some are free, some are no cost. What I'm hearing anecdotally from individuals when I talk or look online is that the free services tend to not work as well. They tend to have intermittent issues. And what I'm hearing is that the paid subscribers, the companies are kind of giving them the full bandwidth and kind of the leftovers going to the ones that aren't paying. So that could be a potential risk you have by having one of those free sites. We have 60 rooms and we have not had any issues with Zoom throughout the duration of the week. The other thing you want to think about is encrypted and HIPAA compliant. I know HIPAA has been waived, and then the question comes up from an ethical situation. I think at least to have the conversation, should I, shouldn't I use, just because the law, right, there's law that allows it, then there's the ethics, and I think you have to make that for you. As I read it is that I still have the ability to do the HIPAA, so I really want to use HIPAA to really try to make sure that I protect the client to the fullest of the ability I have, at least within my practice. And so that's where I've chosen. I don't want to get into a situation where something happens and it's due to a non-HIPAA compliant, and then later on try to explain that if I had access to HIPAA compliant? Why didn't I use it? And I know cost is really the biggest barrier here, and some of them are more expensive than others. And I think that's an individual choice and risk assessment that you're all going to have to make. But at least kind of really think that out. I think it's important. There's no chance encounter in a waiting room. I have a pretty decent sized practice, and our waiting room is pretty big, and we get 60 people in a waiting room, which is one of the reasons why we didn't want to have face-to-face sessions at our office, is that they won't run into anybody they know. Once again, just trying to really put out there information to show that, hey, this is doable. Some of the other things about virtual is, particularly as economic issues become a little bit tighter, there's no wear and tear on the car, there's no travel cost, time, or what have you. So it's more convenient and lower cost. It's just about covered under the insurance. Those that have seen some of our prior talks here, I still have those slides, and we'll review it again briefly, much quicker than I have before, going through each insurance and who's doing what. And oftentimes people are doing out-of-pocket sliding scales and available. I will say, coming back to the billing piece with sliding scale and availability, I know we're hearing a lot of co-pays have been forgiven by the insurances and you don't need to collect them. It's state to state, it varies, and information from payer to payer varies, and it's hard to get good information. So we're taking a proactive approach. And what we have done is we are assuming that the co-pays are not covered and we will reimburse. We think that's going to be a much smoother transition, or just management, a way to manage that. Because we do typically about 4,000 to 5,000 sessions a month. To go try to backtrack that is going to be almost impossible. But what is easy, we can run reports and see who's in the positive, and then reimburse that. So our position is, whether they've been waived or not, we're not clear about. It's just way too confusing, and we don't want to add any more stressors to the clinicians, to the admin staff, because we're all overwhelmed as it is. And so we're just going to collect co-pays and co-insurance as is, and deductibles, and we will reimburse. We're really good at that piece. It runs a lot smoother for us. All right. Next, more benefits and risks. Yeah, what should I know about distance counseling, right? Greater patience is needed when communicating with distance counseling. Even just like for this event today, I have 3 computers, all of which it was difficult to get sound with. They're very good computers, they're high end, but I had to use my phone to dial in. Was a little bit stressed, sweating here a little bit, trying to get my backdrop up behind me to make sure that was covered. So I probably could have done a better job. Even though I gave myself 15 minutes, I probably could have used a little bit more. I would ask you to do the same for your clients. It's all new to them. Let them get on and kind of work those kinks out. Also for you, so it's easy for you to kind of go into the room and they're already there. Or if they're not there and they're supposed to be in 10 minutes before, to call them right away. I wouldn't wait for the client to call you or 30 minutes in and say, where's the client? I guess they're no-showing. What we do is we're proactive. When a client's not in the room, we've told them it's 10 minutes, we're calling them. It just really helps facilitate things running a lot smoother. And so these are just some of the small tricks that we've done over the last 2 years that we think that may help you. Also, sometimes you want to email that link ahead of time when you can. I would suggest is that you do it at the time of session. So at the end of the session, you set up the next appointment. I would send the link at that point. Why? Because you can go in spam and junk. It could get lost. So you can tell the client, hey, if you don't get that next 24 hours, check your spam. Get back to me if you don't find it anywhere, so that you don't get run up against that appointment and you find out that you're not able, you just have that disruption and there's already stressors to you. And so just with modern technology and sophistication, glitches may happen. I think just before this, I'm the biggest example of that, having 3 really good computers and having none of them be able to work. One, I can't sign on to the internet. The other one, it doesn't have the software for PowerPoint. And then going on here, it was just a big, great example of why to prep ahead of time. The other thing that is with the video is you can see emotional cues, but they are more difficult to read across the video screen. It just is, right? Depending on the lighting, oftentimes people can be in a darker space, or the computer, where it naturally looks bright, it just doesn't pick it up. So these are some of the things to think about and just discuss with your client, right? So probably a better place is for them sitting with in front of facing a window, meaning they're facing it so that the ambient light is coming right at them and you don't get the glare from the phone. And that is one recommendation as far as lighting. Some people may desire more traditional course of treatment. Those who are actively suicidal, homicidal, those who are actively manic or psychotic, or those are numerous concerns over technology risk. These are concerns, but these are not normal times, right? We're in a national emergency. So we're going to look at these a little bit differently than in a non-emergent time. So if there's no alternative option, I say you can make the case for behavioral health. And we start all our notes with, as a result of the state of emergency declared by President Trump, as well as the governor, who is Wolf here in Pennsylvania, we have switched to virtual or telephone therapy. If it's telephone, we're explaining why virtual was not okay. And we're doing this to decrease the risk for the virus. So you're already in your note, and you can make that kind of a standard cut and paste if you want, explaining why you're doing what you're doing. And then further talk about that there are further complications with dealing with these individuals who are suicidal, homicidal, psychotic, manic. But however, due to the current pandemic and state of emergency, you explain that this is why you continue to do this method in the sense of a harm reduction. And I think you make the strong clinical case for that. And I think that's sound clinical judgment. The other suggestion is whenever you're concerned about any of these ethical issues, talk to a few other clinicians that are licensed. Document in your notes that you discussed this, and this was a decision you came to after talking to multiple clinicians. It really just shows you've done your due diligence, you've spoken to your peers, and that there's some level of consensus due to it. And it just shows that you've done your due diligence. And I think just gives you stronger footing for these times. And what are those other numerous concerns over potential hacking, eavesdropping, someone signing on that shouldn't sign on? So if you share a room with someone, with another clinician, you only have one room. Will they sign in and then see the client when they shouldn't have? Those kind of things. Just those kind of concerns you want to be worried about. And for everybody online, I'd appreciate you just mute so that we don't have any extraneous sound while, at least during this portion. I'd appreciate if you could mute your side of the audio here. All right, assessment and contingency planning, all right? Symptoms, what would they exclude, crisis versus normal times? So we're really talking about crisis and talking about delusions and hallucinating, suicide. We kind of just addressed that. But does this person need to be inpatient? One of the other things that's very difficult during this time is where can they go for a higher level of care? And I have a great resource at the end. I think there's some really key things and resources for you to go with at the end here that are going to be really helpful when you run into some of these other difficult situations to really take that workload off you. So you just want to be careful, right? Do they need a higher level of care, suicidality, delusions, or hallucinating if they're psychotic? And how do you get that? Or can you really do harm reduction? You just really want to kind of think about, we're not normal times and we're in crisis time. All right. So how do you currently assess the suicidality, right? So there's different ways, and I have these resources you'll be able to click on. So with regard to assessment, there's two listed here. There's one that is derived from the Beck Depression Inventory. If you click on it here, you can get it. Yeah, I'll be able to click on it there. So what this one is really quantitative, which I like, is that you can have a client and fill it out with them and it'll quantify it. And based on that numbers, it'll kind of give you general guidance. Ultimately, you have to do your clinical or have your clinical decision-making process and how you're going to act. But this is a great calibrate. It almost gives you like a thermometer, mild, moderate to severe, to help you make your decision on, hey, is this manageable at home? Do they need to go to a higher level of care? And the other one that we have here is the CSSR, which is the Columbia assessment. We use this at our office. And this just really part of your assessment and documentation, but also it helps you with your documentation for dealing with individuals that are struggling with homicide or suicidality. And oftentimes I really haven't had a really good homicidal assessment, but oftentimes I use these assessments and I just interchange in homicidal thoughts rather than suicidal to help guide me. Even though clinically it hasn't been validated or related, I do feel it's well organized, and it's good to it's good to add to my qualitative assessment. Two resources I think that's very important is the National Suicide Hotline, which on this little tab here, when you click on it, it'll bring you there with the resources as well as the phone number to have your clients have, as well as crisis text line. This text line, you have a client text this and they're in crisis, they can text at any time of the day. And the nice thing about this is they have some type of computer algorithm where they can identify how these individuals are texting whether they're at high risk for completing suicide, and they oftentimes are able to send help to them. So that's just an interesting kind of fact there. And here's some resources for suicidal clients on and how to kind of begin to have some information, right? And so what information do you need? It's a little bit different. When they're in your office, you know where the clients are. If you need to kind of get a high level of chaos VO2, it's a little different with virtual. So probably one of the things you could do is check in early on if you have any thoughts of hurting yourself or others. And probably what you want to do early on for new clients, and maybe get, if you don't have it already, for clients already established, it's where are they physically located when you're doing these sessions? And I would check in with them and validate that that's the session they're at, that's the physical location that they're at while doing the session. Why? Because if they are suicidal, homicidal, how are you going to have services get there to either protect themselves or protect others? So by knowing that their location, then you can go and do the research for who's the EMS, police, fire department, emergency contacts in those particular areas. Or if it's a child or adolescent and child and youth services needs to be collected. If you're seeing clients in that area, you need to be able to have that information at your fingertips. So one would be proactive to have that ahead of time. But if not, at least at the time, you need to know where they are so that you can access that, as well as potentially other supports, family members, emergency contacts. Actually, why did I do this? Technology issues, what type of internet access do you have and the client has? Not just the type of device, but how fast is the upload? Some people, you know, they get the minimum amount to get internet, and it may be okay for email texting, but for video it requires something different. So whatever software you're using, you want to know what's the upload and download. For example, Zoom needs 100 kbps. And so how do you know you have enough? So fast.com is one of the locations you can go to and go and test the speed of your internet as well as your client, because otherwise you're going to be disrupted. And so that can be really, we had an issue at our practice early on that we recently fixed with regard to internet speed. And so we had lots of interruptions. It was just very disruptive. And so one of the ways, if it does happen, is if you want to maintain the video, because it's mainly working, but sometimes not, is you can mute your computer. And then what you want to do is then use the cell phone and call them to their telephone. So kind of you're using the phone for the audio and then the screen for the video, because the video may be intimate, but at least the voice won't be. So that's one creative way that you can go about doing that a little bit differently. So just want to be careful of what the requirements are of the software, as well as the actual internet itself. It's very important. Consent. You always obtain consent prior. So if it's a new client, you want to have the consent prior to getting into that session. Otherwise, you're going to run into issues, potentially. And typically, what I have here embedded in my website, not your website, is this is where you go to my consent for treatment. And we have several different domains in our consent: financial, HIPAA, distance counseling. And what happens is people have to initial online, and then they have the PDF they can click on and download, and then they sign at the bottom. You can see that. What I would ask you to do is that you have full access to that. Go check it out. I give you permission to use anything on the website that you want to take and put into your website. You have my permission, but it's going to be important. But those individuals, they can fill it out and sign the consent, and it already maps over to us, so we can see it and put it in the chart. Or if you don't have that ability, which probably don't if you're on this call, DocuSign and other software is that you could go and get your current consent and adapt it for and add those additional consent needs for distance counseling, and make that document writable. Email it to the client where they fill it out and sign it online. They can either do it with their finger or with the mouse, and it'll email it back to you so you have it in person. When we have clients that don't fill it out, we have them fill it out at the beginning of the session before we get started. We have the conversation, and then we make sure they sign it, because consent's going to be the biggest thing. You want to have the conversation up front because you want to make sure they understand all the risks, benefits, and difficulties with distance or telephonic. You want to have consent for all that. You want to have You want to have the finances all worked out, as well as everything else that you'll see that we have to make sure that they have. And so we want that. And if not, we want to do that while they're on the call with us or in the session with us, and we watch them do it so that once it's signed, we can go get it elsewhere, but we know it's done. Other methods you can do are email. So you email them a blank form. They print it and fill it out, and they can either fax or email or give a picture back. Also, you want to be cognizant of that either whether it's fax or mail, that it is HIPAA compliant. I know they've waived it right now, but that, who's going to have access to your email that easily hacked? Is your password 123, that kind of thing? You want to make it a little bit more complex. Also, you can do it snail mail. You mail it to them and they mail it back to you, but also, again, what happens if they don't have it at the time of session? But those are other methods that are possible. You have to kind of work out your own system. Even when we're not on this call and afterwards, my contacts, feel free to shoot me a text and email, let me know if you want to chat. I'm willing to talk to you and kind of help you out with this. This is not an easy time, but it's doable, and you're capable of doing it. So I came across this a little bit earlier today because people are like, hey, is this going to be helpful? Is it efficacious? There is a ton of literature supporting teletherapy. There are peer-reviewed papers that support its use in anxiety, autism, couples and family, which people have been hearing a lot. Is that possible? Yes, we've done it also. Depression, insomnia, eating, trauma, self-harm, and suicidality, and there's also other great links. So this link down here is to Division 12, Psychology, Division 12. Use this. This is a great resource. It'll tell you any diagnosis and what has been shown by the literature, which modalities, interventions have been shown to be strong, mild, or moderate. It also it's starting to list that virtual's also been shown to be efficacious. So you want to have that support and feel more confident, right? Because this is all new. It's like, so okay, I can do it in person, but is it going to work? So now you can, read the literature. You can have that confidence that this is just as efficacious, because you want to have that confidence when you're going into a client. You don't want to be distracted by all that. Okay, so this is insurance and billing for you that have been on any prior, you've seen this, any prior calls, you've seen it. I'm going to go over this briefly. But currently, all plans, currently covering all plans, you bill with a GT modifier. So you bill typically you're billing a code, a 90837. You're based on time. You continue to do that, whatever that is. Then after you do your time code, you add the biller modifier, GT, which lets them know that it is virtual. And then a place of service, because you're probably doing it from home or maybe the office, you need to indicate a 02. Like I said, okay. And that's for Medicare. For Medicaid, currently allows via telephonic, also via virtual. We're hearing it depends though on county. Not all the counties in Pennsylvania, they all have different rules. So it was really impossible for me to get a comprehensive list. So what we do know is that there is, they do allow virtual and telephonic depending on which county, and you want to call your county executive for the behavioral health to really find that out, because it varies. It's very complex. But I do know there are states, and I know we have some partners that are doing that. And also how you work out the billing. UPMC is mostly in Western PA and across a lot of Central. The currently plans, the commercial and Medicare products are virtual. You bill with a 95 modifier in place of 02 as far as location. Highmark, all right. So we're talking about Highmark in Pennsylvania, not Blue Cross Blue Shield across the country. Each state tends to have their own Blue Cross Blue Shield and sometimes also multiple Highmarks. In each state, I would suggest trying to get the best information as possible. Virtual coverage typically tends to be covered now in most states, but you bill it, if it is, it's G2 modifier with a place of service 02. But outside of Pennsylvania, it's difficult for me to get much information for you, and I apologize. Currently, Aetna is covering all commercial plans and Medicare plans. Same thing, you bill with a GT modifier and place of service is 02. United, you bill with GT and place of service is 02 for both commercial and Medicare. They are currently waiving the typical attestation form, as well as, I believe that's for, no, that wasn't for United. For United, typically you have an attestation form you have to sign. They're waiving it now. I would always suggest when we get back to normal times, just be aware of all this. With the Medicare, with these attestations, they may pull that back, and then you're going to start getting bounced. So just keep a mental note that once we normalize and get out of this crisis, that that you make sure that what the regulations are at that time, so you get covered. They're currently covering all plans, virtual, TRICARE, you bill 95 modifier and pays 02. Cigna, virtual coverage is still administered in accordance with the plan's benefits. They tend to be covered by most plans. Typically, Cigna plans that begin with the letter N had not been covered by telehealth, but that may have changed. But typically, that's how it had been. You must use a HIPAA-compliant platform to conduct sessions. Clients who do not have access to technology participate in virtual appointments. Modifier is a 95, and place of service is 02. And all these you're going to get in email. Magellan, typically you're going to be doing a 95 modifier or GT. You can use either or in the service place of 02. If you're going to do phone session, you use GQ. I don't know if the billing is different. GQ is a modifier for Magellan telephonic. And then you want to use a service place of 02. And they also have an attestation that they are waiving. But also you want to be careful for post-crisis whether that's still there. So we talked about helpful tips just for clients. Sign on 10 minutes early, allow for extra time for any difficulties. Make sure the client knows that they're in a secure and quiet place, and create a code word. So this is a word that a client uses when they no longer feel they can talk freely on the phone. So if it's bananas, when you're having a general conversation, you're doing your therapy, and they say bananas, you know, hey, something has changed. And maybe you do another code word for when it's okay or safe, where they just verbally tell you. So that's just something to consider while doing virtual. A little less control over the sessions. And I know many people at home with kids and family, can't tell you enough. You want to make sure that the family members and friends who are staying with you are not able to hear what you're saying or the client. It's going to be very important. Use headphones or earbuds, and we talked about the code word here. So some helpful tips for clinicians. Confirm at your professional liability company that your coverage includes telehealth. There are some coverages that exclude telehealth. So you don't want to get caught unprotected unknowingly. So you want to be able to do that risk assessment appropriately. So please reach out to your liability insurance, professional liability insurance. I suggest using HIPAA compliant software. It just decreases that one layer of risk that you don't have to worry about. But I understand everybody's situation is going to be different. You have to make your own risk assessment, part of which we've begun that conversation today, for you to make a the best fully informed decision for yourself. We talked about a physical address of your client at the beginning of session for the safety reasons we listed earlier. And I would create a plan for patients' payments and communicate it with clients. We're pushing mostly to use credit cards when possible, because it's just going to make it a lot easier for collecting. We have a HIPAA compliant safe vault where we can store in a cloud-based system with credit cards, so we don't have to worry about that. We're trying to tell clients to send payment ahead of time if it's check only. It's just to be proactive, particularly at a business of our size with everything else that's going on. It just creates another layer burden of work that's just really going to create more problems. And we're all trying to be flexible with clients with payment and otherwise. But the reality is also for you clinicians, there is a certain level of finances that you're going to need to sustain yourself and your family. So we have to be cognizant of that too. So trying to create a plan and implement financial policies that keep you afloat during this time till we get back to normal times is going to be important. And it's okay to think about that. I know in a helping profession, and oftentimes money feels uncomfortable, but we're doing the best we can here, and you're valued just like everybody else. So that's my words on that. So clinician anxiety and virtual behavioral health, right? Does virtual work? Here's some additional references I have and some other links from the NCBI that talks about the efficacy of virtual therapy. It is efficacious. You can feel confident with that. There are really robust trainings you can get out there if you do some searches with Marlene Mayhew does a really good strong one. That's who came in and did one for us. I know she's cut her fee by, it's online at your own pace, but she's cut it by 50%. as well as I think PESI has one that may be for free now. It's 11-hour training. So what are the treatments for trauma? So really what we're working at is acute stress disorder and trauma treatment, right? So what are the treatments for that? Psychotherapy, medication, and free spirit. And I'm going to talk a little bit about these. So what's trauma? Acute stress disorder. What is it? It's a disorder that occurs within 3 days and less than a month from a specific situation. This particular situation, it's this virus that most people are fearing. They tend to mimic a lot of what PTSD does. It's just a little bit difference with timing and number of symptoms. Some of the risk factors are having prior traumatic events, history of PTSD, a history of mental problems, anxiety or what have you, and 80% of individuals diagnosed with acute stress disorder tend to go on to get PTSD. That's why the importance of individuals getting the treatment early on is going to be important. So although I know that it feels like there's a pressure, I think everybody's just trying to organize how do we maintain and survive. I think there's going to be an increased need from what's already there. It's about how do we make this economical. So getting the proper training is going to be important. And if anybody needs training in trauma, CBT, here at the Cognitive Behavior Institute, please let me know if you're interested. We'll try to put some smaller 1-hour sessions, but other robust ones if there's interest at the lowest cost possible. My goal for this week and a few weeks is to put out a lot of free content and then go to low content where you're paying. We can get a lot of people on for a low price where it makes sense to support it, but it's peanuts, where if you get 100 people to come on and everybody pays $5, $10 and get some CEs, but it's robust to help, but also can help support some of the individuals doing the training. We're going to look for this model. We're not sure what it is. So that said, acute distress disorder, the symptoms. Criteria A, you need 1 symptom more from that criterion. I'm sure you all have a DSM. Criteria B, 1 symptom or more. For criteria C, it's actually 1 symptom from the criteria and not 3. And the same thing with D. It's 1 criteria from D, E, and H. And the treatments for acute stress disorder, it's cognitive behavioral therapy and debriefing. So when I say that, that's what the literature is showing. There may be other methods. There just hasn't been literature done to the extent that I have comfort level with. So just want to kind of caveat there. So that's what I'm kind of saying. What drives what I do in my decisions is really what the literature shows, and then adapt it to clients. So that's my frame. So understand when I say that's when I give a recommendation on treatments, that's my frame. With regard to PTSD, typically you need 1 more of this. An event, which probably most clients will now have at least 1 symptom from criteria B, 1 symptom from criteria C, 2 or more from D, 2 or more from criteria E, and it lasts for more than a month. So that's when the acute stress disorder switches to PTSD, and that's part of your assessment. And really, the 2 treatments that have been shown, at least the strongest amount of literature and has been researched, is prolonged exposure and CPT. There's great books with manuals, treatments that work, that have that I would strongly suggest doing. The person who created prolonged exposure, Edna Foa, came and trained my whole staff. And so we're strong with that. We have that ability to help others. If you could just mute, I'd appreciate it. Thanks. And CPT. Let me see here. I can't find the mass mute button here, but we'll just move on from here. All right. So one of the interesting things that's not medication related and is not therapy related is Free Spirit. I'm not sure if you're aware of Free Spirit. I've been using Free Spirit for 4 years, and it's been cleared by the FDA for the treatment of panic disorder, which I've seen a lot of increase, and PTSD. And really what the premise is that the breathing pattern changes with individuals with panic and PTSD. We begin to breathe more shallow, irregular, and really how the brain begins to monitor that is that there's an event going on that is a threat to them. So even if someone is at home in a rural area no one comes to visit them. They haven't been out in a month or so and don't really have any exposures, but still think they may have it. The brain will, just the thoughts will begin to kind of create those PTSD symptoms. And what we've really been doing is using free Spira as an adjunct to our psychotherapy and psychiatry, and have found that our clients tend to get better quicker and more likely to get increased improvement on whatever assessments we're using. We used it, I think it's the PCL civilian, PCL-5, whatever assessment you use for trauma, and begin at session 1, and then upon completion and over time we're seeing people get better. So just once again, those that are on, I'm hearing some of your family get very excited behind you. If you could just mute, I'd really appreciate it. And so basically, you get individuals begin to breathe in a different way. They get air hunger. They get dysregulated in their breathing, and their CO2 levels begin to dysregulate. And you actually can measure that with free Spira. And then you start getting hypersensitivity to the neurologic symptoms, and people who tend to have more panic attacks and more of the intense feelings of PTSD. And so for anybody that wants to look into free Spira, let them know you heard about it here. I'm not getting paid for this, for any of these things that you're listing here. These are just things that I do. So for free Spira, I have it listed here below. Reach out to them, let them know you heard it on here. Another book, the books that I use oftentimes, the Treatment That Works series, it's very good. It's all evidence-based. They have manuals that you can use for prolonged exposure, for CBT, for stress management, for panic disorder, for you name the diagnosis, you're gonna find it. There's a list of EBTs for PTSD and trauma, this link below here, the diagnosis, as you see for PTSD and their symptoms. And also, what could be a very difficult time is oftentimes people need that extra supportive medication. But how do you find a psychiatrist? That's something that we have capacity here at Cognitive Behavior Institute. We don't ask clients to force them to see our therapist. You get to keep your clients. We are what we call patient and therapist friendly exterior. So if you have a client, you can have all the confidence in that when you refer them to us, you can keep your clients. All we do is we do initial biopsychosocial assessment with one of our clinicians prior to the psychiatrist, so that the psychiatrist can spend the dedicated time on really focusing on the medication piece with them. It's just a one-time assessment. And our psychiatry loves to get feedback. They love to talk to you. They love to collaborate with you. And typically for adults 18 and older, we should be able to get them in within 10 business days. And we are virtual. So if you need someone that needs to get, it could be a little bit more complicated for someone needing stimulants, but non-stimulant interventions, it should be pretty smooth, and it's a great resource. So anybody who needs psychiatry help, the website is psychotherapy.org, and our phone number is up there, as well as free Spira. So if any questions about any of those, hopefully that's helpful for you, and you can let me know if there's anything else. Like I said, I believe at the last slide I have my cell phone. Feel free to text me, email me. You could try calling. If I'm not available, I won't pick it up, but you can leave a message. But texting or emailing me, hey, I got a question. I want to talk to you about this. Hey, I want to talk to a psychiatrist. I want to get to know your prescribers. I want to develop a relationship. Our prescribers are willing to do that. They'll talk to you before you even refer, so let us know. And this is where you can refer with confidence. You get to consult with the psychiatrist, the one-time biopsychosocial in 10 less business days. This is the office number you see here. This is my cell phone number. If there's any glitches with anything, please reach out to me via email or cell phone. We want to help you through this. Okay, we're here for you. We know it's very difficult, and let us know how we can be supportive. We can only be as strong as the group, and we're here for you. So someone else I use, this is not anybody related to TBI, but Stephanie Burkle with Acadia. Whenever I need someone with a higher level of service, she basically gives white glove service. I ask permission of the client, hey, can I give your information to Stephanie? Stephanie will call the client and then find, and if you give her the insurance information, it just makes it smoother that way. She will call the client and she will get them set up either with an Acadia or outside Acadia, close to their physical location away. She will give them the best unique option for their situation. And she has just made my practice of 60 clinicians just a whole lot easier, because when you need that higher level of care, you know the casework that goes along with that. And during a pandemic like we're in now, it just creates another level of burden that just makes it very difficult. This is her cell phone. This is her email. I spoke to her today. She said, give it out to you. Reach out to her. She has just been been solid for us. So I just wanted to kind of give out some of the things that have been helpful to us.
That extension.
I also want to share with you is you can follow us on a Center of Education website, our Instagram or Facebook. We're putting out information all the time. This is the best way to do that. So I want you to kind of have that information. We'll email this all to you. And as I say, we are quarantine strong here. So we're all going to stand strong together. And however we can be helpful, please reach out to me. And what I'm going to do now is go to the chat session. We're going to do our Q&A. I'm going to stop sharing here. Let me see if I can get to the chat. All right, I see some questions are already there. All right, let's see here. All right. I'll check where the button is. Well, mute. It looks like Sonia had put a hotline out here for LGBT hotline. Trevor Project, thanks for that. That's good information for everybody. If you check out the chat, you can see some supports up here. Okay, do out-of-network providers need to fill out the paperwork to be telehealth providers for each insurance company during normal times? So this is one of the things, we're not out of network with everybody. So typically what you want to do is when we had anybody that was out of network, we reached out to the insurance, and what we have always done is, because billing, I didn't want to be an issue, and collections are typically above 99% for us, is that we verify the insurance ahead of time and find out what their coverage is, whether it's in or out of network, and we communicate that to the client. And by doing that, that has allowed us to have that conversation and not have an issue, whether they be in network because they have a huge deductible, or they have a huge copay or co-insurance. We clarify that ahead of time and then give them options. It's like, hey, do you want to proceed as is? Do you want sliding scale? We have interns, we have postdocs, we have therapists, depending on what people can afford, and try to adapt it to them. So what I do is that some telehealth you can do without contacting, but you get different answers. So we verify that, to be quite honest with you. It's confusing for clients, and so we have our billing experts reach out and do that. We're going to have our billing expert here on Wednesday do an hour show, just Q&A, not really more presenting other than those slides specific to insurance, but she's just going to be here for Q&A. What other questions do you guys have? Sure. So the question I'm reading now, which you're probably often to see, is are there resources? There's lots of resources, and we're going to be posting them. Whether it be one is when, like today, I can share my screen, and oftentimes kids have devices that you can share, and so you can have them draw on the screen their feelings, and you can see them while they're doing it. You can have them try to use it. What I would suggest is, what would you do in person? You really can do that virtually. So if it has to do with artwork or drawing, it's just they can get a piece of paper at their physical location and draw and then describe to you. Or what you do is you can ask them to draw it and then put the camera on and observe them doing it. You can do play therapy. And I do have resources which I'm going to send specifically to kids. We actually have quite the large resource, and I'll send that on. I'm just thinking of some things now. But you'll be surprised. These kids can really be engaged. Oftentimes I find that if we create, I'm a CBTer guy, so I like to create a structure for my session. What am I going to do at the very beginning? What things are we going to target during and after? Typically it's 1 or 2 in person, and I pick 2 to 3 when it's virtual. And what I do is I begin to think about is, 1, summarize what have we been doing between sessions, what was helpful, what wasn't helpful. So I'm already gathering on what's going on, how are they functioning, and of course I'm checking in how are they doing in their family overall, because that's what's on everybody's mind. Then, what are the interventions I'm going to do based upon what is on my agenda for what this child or adult wants to do. And then, so if it's a child at 5 years old, what are the typical things that you're doing with them? You can do artwork with them, you can do play with them, and we'll send you some of those resources that we have with, we'll attach that here to the slides when we send it out. But I would say you're fully able, but those creativeness beyond, getting creative beyond that, I'll send you the specifics. But I hope that was helpful. So just stay structured and summarize, and I think you'll be good. Okay, let's see, next question. Telehealth recommended for group treatment? If so, do you have resources to help them with? So when you say resources, what specific things about groups? So for this, like for the platform I'm using for Zoom now, we could do a group, and I could break you all down into pairs of 2, and it'll automatically do that. And then I can go in and out of each room with you and kind of see what you're doing. So you can do kind of a larger group and then break people down and do the exercises. And so it's very much like you would do it in person. It's just really getting used to the virtual world of it, but it's very similar. So one, you want to make sure, do you have the right technology? I'm going to make the assumption if you're using a free technology, it is not likely to have some of the abilities of the things I'm doing as far as to be able to do that. But also think about, in harder economic times, groups may be a more economic choice for many people. So, right, it's different if you want to get $80 and people can't afford it. It's another thing to get 8 people in a room at $10 that's more feasible for them. And so it's just another creative way where you're trying to manage your volume and trying to be cognizant of economics of others. As time goes on, I suppose economics is going to be more of an issue, but also you have to worry about your own economics. And it's okay to say that out loud. It really is. And so I'll just say that. So it is doable. Yolome is a very good person for groups in general. I think you just have to adapt that to that. We're doing groups, we're doing support groups, we're doing an addiction group that's online, and we're getting more creative with them. So we're learning with you. And so as we come on and we create these things, like I said, follow us. We're going to continue to post. We're very comfortable in the virtual world. We're just adapting it to it, where I can understand not being in the virtual world, you're kind of getting used to that first. So we'll maybe just be a little bit ahead of you, and so we can help you with that as we go along. What else? Any other questions? All right, on the school level, we typically assess and refer out for immediate treatment if student meets criteria. What should the protocol for referring to a student to an inpatient, outpatient program, or even to a therapist? I think you keep it the same. Your assessment hasn't changed. It's just the dynamic for which world you're in. If they would meet criteria when they went to school for, meaning in the physical face-to-face school for needing therapy, in the virtual world, the same thing. You have to make sure that the individuals that you're referring to have that ability. Level care, she will take white glove service. I would just say, just pass it off and call her or email her. If you need help with outpatient for therapy and psychiatry, we can be helpful. But also, what I would suggest is create a post in the Center of Education or my CBI Facebook. Say, hey, use that as a referral source. Make a post looking for a referral for a client, or I'm open for referrals. So let's be a support to each other, or to refer to or to get referrals from. And go to our Facebook page and do that, either on the Comfort Behavior Institute Facebook page or the CBI Center of Ed Facebook page. Just make a post, hey, looking for a referral or I need a referral. And we'll just use that as a source for us to be able to get resources together, either to get a referral or to send a referral. And like I said, you have my email and my phone. Feel free. Feel free, yeah. Because I know many of you are going to be from all over. So we may be having people travel elsewhere. So it'd be good for us to have that. Let's see, is there anything that you would say to help clients feel more comfortable in the beginning of your treatment? I know online video, natural and different. Well, what I've kind of taken is I give the virtual discussion like I do talking about sex with clients, because people can be uncomfortable, right? So I talk matter-of-factly like it's not a big deal. So when people come in and they have issues with ED or otherwise, and you can see they're beating around the bush. You've probably been there, right? It's just like, I just call it out. So, okay, so you're having trouble getting an erection. Tell me about that. And so I just normalize it. I don't have a reaction. So same thing with telehealth. When we call people and transition them, we really didn't have pushback, what I would say 90%. We say, okay, due to the emergency, we're transitioning to virtual. So we're going to send you a link. We talk matter-of-factly. We watch the body language, or we listen for body language. We get virtually. Most people have transitioned. So I think when we feel awkward about it, we can transfer that to our clients. So I think talking about virtual like you would sexual related issues with clients, that's just matter of fact. It's okay to have that, but this is natural, we can do it in this day and age, meaning the virtual piece, that I think they won't be as reactionary. But I think just like with any issues, what are their fears? What are their concerns? What are the barriers? Because there could be real concerns, confidentiality or other things, or abuse. We just have to work it out and be creative. And hey, let's go back to CBI, Center of Ed, or our regular Cognitive Behavior Institute page and make a post. Let's help each other and support each other. Let's have a central area to do that. You have my cell phone, my email. I'm going to be available. I'm trying to cut back on clients to support my own therapist and community at large. So I'm available for you when those more specific things come up. I would just to summarize, talk about it like it's natural and just talk about their fears. And then it's also okay to share your natural fears when it's supportive, right? You don't want your client supporting you, but when it's like, hey, I'm human too. I was a little bit anxious about this at first. These are what I worried about. I'm hearing this is similar to you. Is that what you're, right? So you're pivoting. It's all about the client, but also showing you're human. I think that's okay. Let's see here. Thank you. How many participants per group are appropriate? So we're using a model, since I haven't had any literature to support that. We're using kind of max 10 is where we're saying for groups. But I mean groups, therapeutic groups, support groups. We're going a little bit more because of the cost factor. We're going to be doing a lot of support-free groups. So we have limited supply. So it's a nature of supply and demand. So we're going to open that up and see, probably not 100, but so we're going to be doing, I think, this Saturday coming up. If I'm wrong, if Erin's on, if you can type in the comment box here. Erin's my chief operating officer. I think she was on earlier. Is we're going to be doing kind of how do you talk to kids during this time, right? So we're going to be going from basically the really young kids to child and adolescents. We're going to have one of our child psychologists and therapists on working together just to tell people, parents. So that's one way to, even if the therapist maybe wanting to go to the virtual world and hearing that may be helpful. But I think just normalizing it, it's not different. It's just getting used to something that's different. And as I tell people, you can look at this as oh my God, another problem, or as I look at this as another challenge, another part of the journey for me, something to get proficient with and help and support. So I get excited. I don't know if you can pick up my energy to be able to help other people, but so I just use this as another opportunity and just, give off that vibe. You can own that. You can do that, no doubt. Let's see here. Any other questions as we wind down here? All right. I hope this was all helpful to you. If there's any positive, constructive feedback you think that I can help improve this, realize in an hour, snippets, is hour a good time? Is 30 minutes better? Should it be longer? I'd appreciate it. Let me know. Also, those slides for all those resources. If you need psychiatry, feel free to reach out. Let's be a referral source. I see everybody. I see from California and beyond. People are on here. Go to CBI on Facebook or the Center of Ed and make those posts. Hey, I need a referral, or I'm accepting referrals. It's cash. I do sliding scale, population. Put all that data in there so we can refer back and look. Let's be a support for each other. And I'll see you soon. We'll have some other information out here in a couple of days. Everybody stay healthy. Wish you and your family the best. Take care.